Everyone, so welcome back again to the day 2 of pathology revision. So yesterday we had 20 questions. We have discussed each and every topic that is very important, more of the basic section. So today what we are going to do is that we are going to discuss the rest of the topic, more of the systemic pathology. Okay, so if in case you have missed yesterday's video, please do see it because those topics are very important for your exam and that is a must know. So please go and watch the first video if you haven't seen it, and also share to your friends because this will definitely help you with the exam. And also I have shared some illustrations and mnemonics that can also help you with the exam. So today we are having another 20 questions and some other high-yield topics from the systemic pathology section. So let's see what all I have included. So like I said yesterday, if you have a piece of paper and pen, please write it down what I'm saying that feels important to you and that can help you remember. Please write it down, or you can screenshot and keep it on your gallery so that you can just swipe and see before you go to the exam. All right. So let's not waste our time by loose talks. Let's just jump into the class. So okay, we are having, so I just told like it's the day 2, high to moderate yield, and this is must read. Okay, you should go through all these topics before going to the exam. So let's go to the first question of the day. I'm going to read the first question. If both parents are suffering from beta thalassemia trait, then the chances of child being deceased are. So here we are talking about beta thalassemia, right? So what is this beta thalassemia? It is autosomal recessive. Yes, it is autosomal recessive. So how does this work? Let's show. So I'll show you how this is working. See, we can consider this A as a normal allele and the small a as a diseased allele. Fine. And consider the mother. So the probabilities of two couples coming together and the combinations that can happen is what? A, small a, this one, and again this one, right? So this is autosomal recessive. So if the person has to be deceased, what has to happen? Both the alleles has to be defective. So the small a is defective here, right? So this person will be defective. This person is going to get beta thalassemia. This is a carrier, this is a carrier, and this is a normal person. So what is the chance? 1/4 chance, right? That is 25% chance. So this is how you understand, you calculate what is the probability of the child getting a disease from the mother or the father. Fine. So what is the answer to this question? It is 25%. See, A is the answer. So hope you understood the concept. This is how you write and see how much percentage the person is going to get. Fine. That is about the. So, and another thing you have to remember is that in autosomal recessive, how do you differentiate between autosomal dominant and autosomal recessive is that in autosomal dominant, all the generations will be deceased. There will be at least one person in all the generation who is deceased. But in case of autosomal recessive, it's not like that. In autosomal recessive, there can be generations where there are all the people in that generation can be normal. So that is how you differentiate if you are given a pedigree chart. Okay, fine. So you can keep a note of that, what I said now. Okay, that is about the first question. So let's move on to the second question. I'm going to read the second question. The second question is, an adult patient presents with fatigue, pallor, routine blood investigation shows low RBC count, low HB, MCV, MCH, so and so. So what is the diagnosis is asked. Okay, so before going into the answer, let's discuss all these things in a short capsule form for the exam. Okay, fine. So first we'll go with IDA. What is IDA? Iron deficiency anemia. So see, in the clinical scenario that is given now in the question, it says what? The person is having fatigue, the person is having pallor and low RBC count and low HB. Where does this come? This comes under iron deficiency anemia. And most importantly, what is the characteristic of the RBC? The RBC is microcytic hypochromic. That is, the size is decreased. And what is hypochromia? The color. It will be paler compared to a normal RBC. So that is microcytic hypochromic red blood cell. So this scenario speaks about what? Iron deficiency anemia. Okay. So the answer is iron deficiency anemia, but let's see all these in like a short. form, like a nutshell? Let's see. So yeah. So the first thing, what is option? Option A is vitamin B deficiency. What does vitamin B deficiency do with our body? When we are having vitamin B deficiency, what happens is that there is vitamin B12 deficiency. When there is decreased vitamin B12, what happens is that the thymidine decreases. When this happens, there is impaired DNA synthesis. When there is impaired DNA synthesis, what happens is that large immature RBCs are formed, because there is DNA problem, right? So the mature proper RBC is not formed. What happens? There is large immature RBCs, and what happens? And these are having improper DNA, that is open chromatin is there, and these cells are bigger in size. What are these bigger cells known as? These bigger cells are known as megaloblasts. So what does this vitamin B deficiency leads to? It leads to megaloblastic anemia. So that is what is about this option B, vitamin B12 deficiency. What is that? Megaloblastic anemia. Okay, next is what? ACD. ACD is the anemia of chronic disease. So anemia of chronic disease, what is that? Like, if a person is having a chronic disease for a long time, a person is suffering from a lot of organ damage, what happens is that, you know about a component called a hepcidin, right? This hepcidin, what does this hepcidin do? This hepcidin regulates the storage and transport of ferrous iron in our body. All right, so what happens is that when the person is suffering from an illness for a long time, this hepcidin is going to be increased. When hepcidin is increased, what happens is that it blocks the ferroportin. When this happens, what happens to the body? The ferrous transport, the iron transport is completely blocked. So the iron is not reaching the bone marrow and the blood and all sorts of where the iron is required, and it is getting trapped inside the macrophages. So when this happens, what is the result going to happen? There is going to be anemia, because the iron is not reaching the source where it is needed, right? Because of this hepcidin increase, and there is no ferroportin to work. So what happens? In bone marrow, there is no iron delivery, and therefore no hemoglobin synthesis. So there is anemia. That is how anemia happens in a chronic disease. So let's see this formula like thing I have written here. Low iron plus high ferritin, because the iron is there, right? In the macrophages, it's stored as ferritin, but it is not reaching the location where it is needed. So if the case scenario shows like there is low iron and high ferritin, then it is anemia of chronic disease. And if it shows low iron plus low ferritin, then it is iron deficiency anemia, because iron is not reaching, the body does not have iron. It's not like it's getting trapped somewhere. It is there, the iron is not there in the body. So both the ferritin and iron content in the blood will be low. So that is iron deficiency anemia. That's how you differentiate between these two. Fine. And next, the option C was sideroblastic anemia. So what is the sideroblastic anemia? Sideroblastic anemia is that this iron is converted to heme, right? So in the sideroblastic anemia, this heme synthesis is defective. How is this heme synthesis defective? Because ALA synthesis is absent. So when it is absent, there is no conversion. When this conversion is not happening, what happens is that there is accumulation of this erythroblast. There is accumulation of iron in the mitochondria, because it's not converted to heme. So in erythroblast, the iron is getting accumulated in the mitochondria, and finally what happens? These erythroblasts are converted to ringed sideroblast. It cannot mature and form mature RBCs, so it is converted to sideroblast. That is what is happening in sideroblastic anemia. So I have created a mnemonic for you to remember sideroblastic anemia causes. The causes of that is ALAS MAD. Okay, you know ALS in this, it's already there, but again see this that is congenital, right? X-linked, and in acquired form there is ALA MAD, that is ALAS MAD. That is what? A for alcohol, and L for lead poisoning, A for anti-TB drugs, M for myelodysplastic syndrome, and D and other drugs. And there are some drugs like chloramphenicol and linezolid that leads to sideroblastic anemia. You have to like remember this mnemonic and also the causes, because this helps you to differentiate between which anemia you're given, so you will not get confused. So you hope you understood the main points of anemia and how to differentiate between them. So please make a note of this, or take a screenshot, or whatever you want. Just keep this in mind. Fine. That is about anemia. And also I have added few blood findings that is seen in sideroblastic anemia. See, it can be microcytic or dimorphic anemia. There can be microcytic or macrocytic, that is called a dimorphic, and there is basophilic stippling. That is, you may have already learned that in lead poisoning there is basophilic stippling, right? Yeah. So if the cause is lead poisoning, the sideroblastic anemia, then there can be basophilic stippling seen and the hemoglobin will be reduced. That's why it's called anemia. So yes, that is the blood findings. So we are done with the question 2. Hope you understood the concept of how to differentiate between anemias. So do well with anemia. And the third question, let's see the third question. The third question is, I'm going to read. 30-year-old patient presents with purpura, renal impairment, hemoptysis and recurrent upper respiratory infection. C. ANCA positivity is seen. Possible diagnosis. Okay, so here we have a few very good names written over there in the options. So let's see all these and then come to the answer. So here, see, first is Wegener's granulomatosis. So what happens here? What is this Wegener's granulomatosis? It is granulomatous polyangiitis. So let's just decode that two-letter phrase, okay? Two-word phrase. Granulomatous means what? There is granuloma formation. What is granuloma? You know, it is a body formed with the immune cells and the macrophages. So there is a granuloma formation, first point. The second point is, it is polyangiitis. Poly means what? Many. Angiitis means what? Angiitis means inflammation of the blood vessels. So there is granuloma formation and there is multiple vessels that are getting inflamed. Okay, that is what is mean by that first point. What is meant by that first point? So, and what is that in the second is that it is autoimmune vasculitis. It is an autoimmune disease that affects mainly the small blood vessels, okay, especially in the respiratory tract and kidneys. So here we can see the symptoms that we usually see in the Wegener's granulomatosis. So what are those? In eyes we can see conjunctivitis, and pseudotumors can also be seen due to the granuloma formation. And in lungs, what is happening? There can lung infiltrates, of course, and there can be a slight bleeding due to this inflammation of the blood vessel. And in kidneys there is glomerulonephritis. And nose, because this always comes from starts mostly, like most of the time it starts with the respiratory tract. So you can see there the stuffiness, nosebleeds. And in heart there can be pericarditis. And in skin, this is a very important thing, there is purpura. So if the question says there is purpura, you have to think about Wegener's granulomatosis. Fine. So you have got the idea of what this is now. And let's go on to, like, I have written the clinical features once more here for like a clear picture. That is a purpura on the skin. It's very important. Renal impairment, glomerulonephritis, hemoptysis, coughing up of blood. And we have already seen there is bleeding in lungs, right? So obviously hemoptysis will be there. And respiratory infection along with the presence of C. ANCA. So if the question mentions C. ANCA, it can be Wegener's granulomatosis. Fine. So these are the other options that are mentioned there. So let's just go through it in a very, very short form. We have Goodpasture syndrome. So what is Goodpasture syndrome? Yesterday we have discussed thing, I think. We have discussed this. Goodpasture syndrome is what it happens with where in the kidney. What happens is that it is attacking the basement membrane of the glomeruli. So what is there? It is attacking the basement membrane of the glomeruli. That is GBM, right? So if it is attacking, what is that? That is anti-GBM. So if the question mentions mention anti-GBM, then it's always good pastures. Most of the time it's good pastures syndrome, okay? And it is immune mediated. And see, there is no purpura. The question said there was purpura, right? So in good pastures there is no purpura. That is how you differentiate. Fine. So you got the idea what good pastures is. And next, what is this? This is microscopic polyangiitis. Okay. In this also, the same thing, it is a systemic vasculitis that involves the kidneys and the lungs, and it shares, like it has similarities with GPA, but what is not there is granuloma formation is not there in microscopic polyangiitis. And what is Church-Strauss syndrome? And in this also, this is also a vasculitis, but what is important here is it is eosinophilic rich inflammation. So if anything related to blood, eosinophil is mentioned in the questions, then there is a probable chance that the answer can be Church-Strauss syndrome. Okay, and it affects multiple organs. Fine. And this and there is ANCA. ANCA is also present in Church-Strauss syndrome, and most importantly, rhinosinusitis and asthma can be a symptom. So if the question says there is ANCA, there is rhinosinusitis, and especially the keyword is eosinophil rich. If the eosinophil rich word is there, then you can confirm it is Church-Strauss syndrome. So hope you understood and got an idea of what all these vasculitis are. So let's just go back to the question. See, 30-year-old patient presents with purpura, renal impairment. So there's purpura. So it's not good pastures. Renal impairment, hemoptysis, and recurrent upper respiratory, and C ANCA is positive. So obviously, what is the answer? The answer is venous granulomatosis. Fine. Hope you got the concept of all these vasculitis. Okay, let's go to question number 4. Let me read the question. Lab report of patient shows HBsAg positive, IgM anti-HBsAg positive, and he came to the hospital for some illness, but these viral markers are found to be positive. So in hepatitis we have different stages, right? Like the incubation period, the acute phase, the convalescent phase, the recovery phase, and also the person who is vaccinated. And let's see how the markers are the trend of the markers in the progression of the disease. So let's see how that is. The answer is acute Hep B. Let's see how the answer came to acute Hep B. You can see this graph. You have to know this graph. This is very important. Fine. See. So here I'm going to just explain the graph so you get a better understanding. See, we have this. This is the x-axis. This is the x-axis and this is the y-axis. So this x-axis shows the month after exposure, and this is the amount of which this marker is found in a blood. Fine. So see the early phase. See here the early phase, that's the incubation or the early phase here. This one. What is there? See the graph here. We can see there is HBsAg. That is, HBsAg is the first marker to appear when a person is infected with hepatitis. So first marker is HBsAg. Fine. And HBeAg is also found on the early incubation period. Fine. This is, and you have to keep in mind, this HBeAg, if it is seen in the blood, what does that mean? It means the person is having the highest infectivity at that time. Fine. So the first marker is HBsAg, and HBeAg is, if it detected, means it is the highest infectivity time of that disease in that person. Okay. And the second one is prodrome, or the acute phase. In acute phase, still the HBsAg will be high. Okay, the HBsAg will be high. And what is the new thing that is coming up there? That is what? Anti-HBc. Anti-HBc is going to be very high in acute phase. So this is a new thing that is, and still what? Here the HBeAg will go down. At that time, the HBeAg will go down, and HBsAg will be there in this acute phase, and anti-HBc will be also there in the acute stage. Right? See, in the acute stage, you can see this and this, right? Here, this and this you can see. So these both are present there. Okay, but this HBsAg is gradually declining. And next, the next period that we have a Wintour period, and this is a Wintour period. Wintour period, only one marker is there, that is anti-HBsAg, anti-HBc. So you have to keep this in mind. In Wintour period, which one is found? Anti-HBc. Okay, Wintour period, anti-HBc is the only marker see. And in convalescent or the late stage, what do you see? As you can see here, you can see HBs, anti-HBs, anti-HBc and anti-HBe. And what is negative? HBsAg is negative. See, all these graphs are coming to the end. So these all are there in the late period, but HBsAg ends here, right? Here. So HBsAg is not there. Not there in the late period. All these three are there. Fine. So I hope you understood the concept of the markers, and if you know this graph, then I'm sure you can answer all the questions that is coming under this. So just please understand this graph. You don't have to by heart, just understand it. Click that image and store it on your brain. Fine. So I have just made few tables for you. So in acute phase, we have already seen all these three are present except HBs, anti-HBs, because anti-HBs come to the last. Okay. And next, in the Wintour period, please remember this, in the Wintour period, we are having only one marker, that is anti-HBc IgM. Okay. And in recovered, you can see both HBs and HBc. And see, in vaccinated patients, we are all vaccinated for hepatitis, the doctors, right? So here, see, anti-HBs is only found in vaccinated and not HBc. So if a question comes like this, if there is both HBs and HBc, then it is what? Recovered person. If it is only HBs, then it is a vaccinated person and not a recovered person. Okay, this is how you differentiate. Please keep in mind this point also, the vaccinated and the recovered. Fine. So hope you understood that thing, that concept. And next is, so let's go to question number 5. So what is the question I'm going to read? Patient presents with hypertension, palpitation and sweating. Aldosterone levels are found to be elevated and potassium levels were low. Okay, so we have a few options here: pheochromocytoma, Cushing's disease, Conn's syndrome, and pituitary adenoma. Let's see all these thing in detail. Not in detail, like for an exam thing, we can see. And let's come back to the question then. Fine. So Conn's syndrome. So before we go on to this topic, let me just say about the renin, angiotensin, aldosterone mechanism. Okay. So you know, see, this is the glomerulus. Imagine this is the glomerulus, guys. This is what I can do now. The best I can do. See, and this is a efferent arteriole, right? And this is a efferent arteriole, and this is what? The tuft, right? And what is there in this efferent arteriole? We have juxtaglomerular cells. You know that, right? Juxtaglomerular cells are present on the afferent arteriole. And what does this juxtaglomerular cells do? They are sensors of the blood pressure, of the blood that is passing through the afferent arteriole. These cells are the sensors. They sense the pressure of the blood. Fine. So when they sense the pressure, in case if the pressure of the blood moving through this efferent arteriole is high, then what is going to happen? Renin is going to be secreted from the kidney. So the renin, what does this renin do is that our liver, right? The liver boy secretes what? Secretes angiotensinogen. Yeah, and angiotensinogen, and this renin is going to come to this angiotensinogen, and this angiotensinogen is converted to what? Angiotensin 1. Okay, and this angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme ACE. Fine. So, and this angiotensin 2 leads to secretion of aldosterone. So aldosterone is secreted, and what does this aldosterone do? It will increase the sodium reabsorption and decrease potassium increase potassium secretion, and when there is increased sodium reabsorption, there is increased water reabsorption also, and also increased hydrogen reabsorption. Increased hydrogen secretion. Yeah. So increased sodium reabsorption and increased potassium secretion. So what happens? The BP, the blood pressure, will get regulated. That is what is happening in RAS, renin-angiotensin aldosterone. Okay. So let's now move on to the Scone syndrome. What is Scone syndrome? See, we have the causes of Scone syndrome is aldosterone producing adenoma. So if the adrenal gland is having a is having an adenoma, it is going to produce a lot of aldosterone, right? So when a lot of aldosterone is produced, or if there is adrenal hyperplasia, or if there is cancer of the adrenal, this aldosterone is going to be increased. Then what happens when aldosterone is increased? When more aldosterone is here, when more, you can take a screenshot if you want. This is cons in a picture. See, there is increased aldosterone, right? So when there is increased aldosterone, what happens? Sodium and water is increased reabsorption of sodium and water takes place in kidney, right? So there is lot of water. So what does that do? It leads to severe hypertension. Lot of water means increased cardiac output and increased blood pressure. So there is severe hypertension. And what happens? Potassium is lost, right? See, potassium is lost. So there is hypokalemia. That leads to what? Nephrogenic diabetic insipidus. Diabetic insipidus, that is triggered by kidney, because due to what? Hypokalemia. That can lead to what? Polydipsia, that is polyuria and polydipsia. So what? Excessive thirst and frequent urination, and the person can get muscle cramps, weakness, tingling, dizziness, and headaches because there is high blood pressure. Fine. So that is what this the Scone's disease is, and you should know the Scone's disease is a kind of primary hyperaldosteronism, and it is having a long-term impact of hypertension. Fine. So and one thing you have to keep in mind is renin here is normal. Renin is not abnormal, it is normal. So that is a very important point about cons. So this is cons in a illustrative image. Please take a screenshot, revise. I hope you understood the concept of cons now. So now we have the next option was what? Pheochromocytoma. So what is pheochromocytoma? We have the adrenal, right? In adrenal, we have the medulla and the cortex. So what does this medulla secrete? Medulla secretes catecholamines. What are those catecholamines? Epinephrine and norepinephrine, right? So what is this epinephrine, norepinephrine doing to a body? It is going to increase the blood pressure, increase the heartbeat, all sorts of things. If the flight and fight mode of a body is carried out by this epinephrine and norepinephrine. So what happens when there is a tumor in this medulla? These catecholamines are going to increase. When these catecholamines increase, what happens? The BP is going to shoot, there's going to be excessive palpitation, excessive sweating, all these kind of symptoms, right? So what is pheochromocytoma? That is excessive, there is a tumor in the adrenal medulla and there is excessive catecholamines causing symptoms like palpitation and sweating. So, and keep in mind, it is not associated with aldosterone related imbalances. There is no electrolyte imbalance. Okay, let's see the next thing now. And what is next option was Cushing's disease. You all know Cushing's disease, very commonly asked question, examiner's favorite. So what is Cushing's disease? There is this due to the pituitary adenoma. You know that pituitary secretes a lot of hormones, stores and secretes a lot of hormones like ACTH, GH, prolactin and all. So in pituitary adenoma, what happens? If there is an adenoma, there is more ACTH secrete, ACTH secreted. So what does this trigger and form? in cortisol in excess is found in adrenal. So there is, what is cortisol? It is a stress hormone. So it is found. So what does this cortisol do with the body? This cortisol will increase glucose levels. So that means what? Increased insulin spikes. That can lead to what? Obesity. Obesity and insulin resistance also. And this can also, this cortisol, increased cortisol can also lead to muscle breakage. So see that woman sitting there, she's having Cushing's disease. So you can see the figure of that lady. There is central obesity, there are striations, there is muscle loss. See the leg is very leaner there compared to the abdomen, right? Yeah. So and there is thinning and loss of hair, weakness, fatigue. See, the woman is so fatigued and sitting, right? Yeah. And hypertension is there, osteoporosis is there, like the muscle loss, bone is also getting affected, and adrenal hyperplasia is there, amenorrhea is there. So the whole hormone thing is imbalanced in that lady. You have to remember that image, and also what is happening in the body when you have this Cushing's disease. All right. So you got the idea of what this Cushing's disease is now. And okay, pituitary adenoma, we have already said it is what it is. The adenoma of the pituitary, and there is hormonal imbalances of all the hormones that are secreted and stored on the pituitary gland. Fine. So yeah, that is over. Now let's move on to the sixth question. A patient died due to MI. Which stain is used to see the infarct portion of the heart? So yeah, it's here in a myocardial infarction, you have to keep this in mind. It is always triphenyl tetrasodium chloride. Okay, this is the dye that is used to stain the heart cells. What is that? Triphenyl tetrasodium chloride. Fine. And what this compound stains is that it stains majorly the lactate dehydrogenase. We have discussed about lactate dehydrogenase. Where is it found? Yeah, it's found on the cytoplasm of the cells, and it is a very good, LDH1 is a very good marker for myocardial infarction. We have already discussed that yesterday. You can go to the video and see. And there are a few other options there, right? What is Congo red? What is Congo red? It is this pen. Yeah, this Congo red stains amyloid bodies. So you have already studied this. Amyloid bodies stained by Congo red, and under what polarizing microscope you can see green apple birefringence. Okay, you remember that, right? That's a very classic finding of amyloidosis. So Congo red is used to stain amyloid bodies. And Prussian blue, everyone knows it's iron. It stains iron. And Mason's trichrome stains what? Collagen. Okay, and majority, like in fibrosis, if there is fibrosis seen in any organs, then Mason trichrome can be used, because fibrosis always or majorly deals with collagen deposition. So my Mason's trichrome stains collagens. Please keep in mind, Congo red amyloid bodies, Prussian blue is ferrous, and Mason trichrome is collagen. Fine. Hope you understood. Now let's move on to the seventh question. I'm going to read the question. A 70-year-old male with hip pain and lytic hip bone. Okay. Serum calcium levels are raised. So let's see these options. Okay, the answer is multiple myeloma. Now, how does it come to multiple myeloma? Let's see. See, there's beautiful diagram. If you are a fan of this illustration kind of thing, like I love these kind of images, and it helps you to retain things more efficiently. So I have created these for you. You can use them. Okay, let's see what this multiple myeloma is. Multiple myeloma means it is malignant plasma cells in the bone marrow. See, here there is a bone, and the bone marrow you can see big cells, and these are the plasma cells. And there is also increased monoclonal antibodies. And the most important point is Bence-Jones protein in the urine. You should not forget this. This is a very examiner's favorite point. Multiple myeloma is always connected to Bence-Jones protein that is secreted in the urine. Okay, so what is the mnemonic to remember the symptoms? It's the CRAB symptoms, that is increased calcium, renal failure, anemia, and bone lesions. Okay, Those are the and there is another usage, that is this. In skull we can see light lesions, okay, punched out light lesions in skull. That is a very characteristic feature of multiple myeloma, punched out light lesions in the skull. And just see this, you can see the lab findings. What is the lab finding? Anemia, because there is bone marrow is getting what disturbed here, right? So obviously there can be anemia. And this is lytic kind of a change is happening in the bone. Like osteoclast activity is high, so lytic means what? There is more calcium released, so that the calcium is increased, serum free light change is increased, serum and urine M spike is there, and there is anemia also. So you have like understood the topic of multiple myeloma here. Just keep in mind all these things. And now we have a small image of the same, that is the healthy bone marrow. You can see here the RBCs and the plasma cells are normal and regular in number. Here the RBCs is reduced and there is lot of abnormal antibodies deposited on the bone marrow, and you can see what? Increased number and like increased size and number of the plasma cells here, uncontrolled proliferation. That is the neoplastic transformation happening in the bone marrow when the person is having multiple myeloma. Okay, hope you understood the concept. And here this is a small table I have made to differentiate between the plasma cell leukemia, ALL and AML. Okay, these were there in the option, so you get a better understanding. So see, the patient was having what? Painful hip lytic lesion in the question. So here ALL and AML, there will be no bone pain. It is always about the blood picture. It's not mainly about the bone. So keep in mind the bone pain will be in ALL, there can be mild, but most of the cases it is there is no bone pain. And in plasma cell leukemia there can be. And the crab features that we saw now in multiple myeloma, what are those? They are present in plasma cell leukemia, and ALL and AML there is no crab feature. So if the crab features, lytic lesions are seen, it is always related to plasma cells and not AML and ALL. And here see all the organ kind of thing related to the blood, that is the lymph, the hepatosplenomegaly, CNS bleeding, and all these are mainly associated with ALL and AML and not with the plasma cell and multiple myeloma. So if it is more about a blood picture, then go for ALL, AML, and if it's more about the bone marrow, lytic lesions and the increased calcium, all sorts of that things, then it can be about the multiple myeloma or plasma cell leukemia. Okay. So you can ask, you can have a doubt here that why it is not PCL, why it's not plasma cell leukemia. It's not because if it was PCL, then they will be giving a more of the blood picture to you. The blood here, it's nothing is given about the blood. It's more about the bone, the hip, and it's the lytic lesion. So it more points towards multiple myeloma. That is how you have to differentiate with the options. Eliminate the options. But if you have if you have 4 options and you're confused, just eliminate remember the points and eliminate options. That can help more than choosing the correct one. Elimination is better than choosing, I think. That is what I used to do with MCQ. So do that. That can help you, I think. Okay, next is question number 8. Which of the following is composed of phosphol protein? So see, in urine, the most common cast that is seen is the hyaline cast. Okay, the most common cast, and that is formed by what? The protein called TAM phosphol protein. So that is the most abundant protein that is seen in the urine. So this, you can see the hyaline cast photo here. Yeah, that is simple question. The answer is hyaline cast. Keep that in mind. So let's move on to the 9th question. The 9th question is, splenectomy is indicated in which of the hemolytic anemias? Okay, so again we are coming back to anemias. We have discussed already the iron deficiency anemia, the vitamin B12 deficiency anemia and all. That is what megaloblastic anemia. So let's see what this hereditary spherocytosis is. So what is this hereditary spherocytosis? This is a autosomal dominant disease. Okay, what is autosomal dominant? In every generation there can be a person who is deceased, at least one person who can be deceased. In this, what happens is that the RBC membrane is having like a structural protein, right? What is the normal shape of RBC? It is biconcave. Here what happens is that the supporting membrane protein, that is what ankyrin and spectrin, they are not working fine. So there is abnormality in ankyrin and spectrin, and when that happens, what the structure of the RBC is lost. So it turns into a spear. Like, okay, that is spherical RBC. It is not biconcave here. That is what is happening in hereditary spherocytosis. You can see here, see. So what happens when it goes to the spleen? There is increased destruction of RBC because of the error in its shape and structure. So there is hemolysis taking place in the spleen. Understood? So you can see the images here, and the symptoms can be jaundice. How jaundice is happening? When this there is hemolysis happening, means what? There is formation of unconjugated bilirubin, and lot of hemolysis means a lot of unconjugated bilirubin, and this bilirubin is going to get deposited and cause what? Jaundice. That is how jaundice is coming in hereditary spherocytosis, and obviously anemia, because there is a lot of hemolysis, and the RBC is also not mature proper RBCs, and there is splenomegaly, and gallstones can also occur due to the increased bilirubin. Fine. And the only treatment is what? Splenectomy. The splenectomy is the only treatment, and if there is gallstones, you can remove the gallstones. See here, there is an error with the general image. So this is not there. Okay. So let's go back to the question. See, splenectomy is indicated in which of the hemolytic anemia? First of all, this vitamin B12 and iron deficiency is not hemolytic, and G6PD is hemolytic anemia. But this in G6PD deficiency, we do not do what? Splenectomy. What we just avoid the triggers of the G6PD deficiency, and what we just do the transfusions if it's necessary, and no splenectomy. So splenectomy is only done in hereditary spherocytosis, because there is what? Splenomegaly. Alright, now let's go to the 10th question. A 20-year-old male presents with previous infection and hematuria. Serum analysis reveals KFT with elevated serum creatinine. Anti-GBM results found positive. I have already told you, if you see anti-GBM, then what is it? GG, that is Goodpaster's syndrome. Because what? Goodpaster syndrome, what happens? It attacks the glomerular basement membrane, right? It is damaged. So anti-GBM is found in GPS. We have already discussed this, and also these are discussed on the first video. Please go and see that video. In IgA nephropathy, you know, these IgA antibodies are destroying the glomerulus. Okay. So the answer is Goodpaster's syndrome. Fine. Next is question number 11. I'm going to read question number 11. A 60-year-old patient presents with throbbing unilateral headache and nodular thickening along temporal artery. Microscopic examination reveals giant cells and granuloma. What is the most likely diagnosis? So you can see a lot of terms here: Takayasu arthritis, temporal arteritis, Buerger's disease, and HSP. So let's see what all these means. Okay. You already know the answer, that is temporal arteritis. Let's see, just this is revision, so you have to. So the first thing we are discussing is giant cell arteritis. Okay, that is temporal. In the option you saw temporal arteritis. That is giant cell arteritis. So what happens in giant cell arteritis is that it is a granulomatous vasculitis of large and medium arteries. Okay, it is there is inflammation and granuloma formation of large and medium arteries, and here you can see it is inflammatory, it is autoimmune, and it happens on big vessels, medium and large vessels. So the classic symptoms are what? Unilateral headaches, scalp and temporal artery tendon, because the temporal artery is getting inflamed, so obviously there can be temporal artery tenderness, and jaw claudication. What is jaw claudication? When you move the jaw, there is pain, that is jaw claudication, and there can be vision changes or vision loss, and there can be diplopia also. So these are the classic symptoms of temporal arteritis. Okay, so these are the lab markers of temporal arteritis. What is that? There is an inflammation, so this ESR is an inflammatory marker, so it can be increased. C-reactive protein is also an inflammatory marker that can be increased, and liver function tests are abnormal. Why is the liver function test abnormal? Because the cytokines that are released during this inflammation, right, these causes reactive cholestasis in the liver. There is a reactive cholestasis happening in the liver. That's why what ALP, alkaline phosphatase, is increased. That is a cause of deranged LFT, and the platelets can also be elevated. You know all the inflammatory markers, right, in the blood. When you go to the hospital setting, you already know that all will be elevated due to inflammation. And the other options were what? That's Takayasu. Nice name, right? Takayasu arteritis. What is the Takayasu arteritis? Always remember, it is about aorta. Okay, Takayasu. Like when you hear the word, doesn't it feel like a king? Yeah, so the aorta is a main thing, right, in our body. So it always is related to aorta. It is an inflammation of large vessels, especially aorta. All right, and what you have to keep in mind is that it is a pulseless disease. That is, even the aorta is the main vessel that is supplying blood to all of the body, right? So this aorta is inflamed means what? There is pulselessness in the lower limbs and upper limbs. There is pulselessness, and also there is a difference in BP between the upper limb and the lower limb. Okay, and this pulselessness is seen in the upper limb, and there is a difference in BP in the upper and lower limb. Okay, that is Takayasu arteritis. And in Buerger's disease, what is Buerger's disease? When you think of this Buerger's disease, what do you just imagine? A person holding a burger and a cigarette. Okay, that is how I remember. A burger and a cigarette. Both are not good habits. So, Buerger's disease is commonly, and not commonly, it is almost all the time caused by what? Smoking. So imagine a person with a burger and a cigarette. So it's the cause is smoking. So Buerger's disease. What happens during smoking, I'll explain. There is another question. I'll explain that again there. And in HSP, what is HSP? Hinoxnoline purpura, and that is caused by IgA mediated vasculitis. So just remember this: child plus purpura plus abdominal pain. If this combo is seen in your question, then it is HSP. Okay, if it is a child with purpura and abdominal pain, it commonly suggests to HSP. Okay, hope you understood the concept of all those diseases. And now let's go on to question number 12. Question number 12 is, so I'm going to read, which of the following is a marker of intestinal inflammation? It's a very easy question. So intestine means what? It's always related to fecal thing. So the answer is fecal lactoferrin. Okay, answer is fecal lactoferrin. So what does this, an elevated fecal lactoferrin means? What? There is an active inflammation in the intestine. If there is an active inflammation now, then if you check, you can see a elevated fecal lactoferrin level. Fine. And if it is directly proportional. What is directly proportional? The lactoferrin and the inflammation. If the inflammation is high, then the lactoferrin is also high. That is how the lactoferrin thing is. Okay, easy, right? So next is question number 13. A 50-year-old chronic smoker presents with intermediate claudication of the legs. Initially, the pain was experienced during activity and later on at rest also. So we have already discussed what Takayasu arteritis. It was related to the king aorta. Temporal arteritis, we have already discussed, that is the giant cell arteritis. And Buerger's disease. See the question? Chronic smoker. When there's chronic smoker, then it is the burger and the smoker, right? Yeah, so the answer is Buerger's disease. We have a small picture here, see? So what happens here? When the person is continuously smoking, then the then there is a damage in the blood vessel, right? Due to the smoking and deposition, there is a damage in the blood vessel, so there is inflammation and clot formation, and the blood flow is restricted. And when the blood flow restriction is happened, what happens? There is gangrenous necrosis, right? So that happens mostly on the toes and over the fingers. That is Buerger's disease. Okay, smoker with the burger. That is Buerger's disease. Okay. Don't forget that. Important topic. And now question number 14. A young boy presents with a small round cell tumor of the eye. So please remember this. If you hear young and small round cell tumor, it is always retinoblastoma. Okay. Retinoblastoma is very common with children. So young and again what? Small round cell tumor, then it means retinoblastoma. Fine. Remember that. Just make a point on your notebook. So here it's saying the small round cell tumor is a group of malignant neoplasm to have a characteristic appearance. What is the characteristic appearance? It's stained blue. The small round cells stained blue. That is retinoblastoma. Okay, and here we have retinosarcoma and neuroblastoma. In retinosarcoma, what is that? It is the mesenchymal malignancy of the retina. Okay, and in neuroblastoma, it is a solid tumor that is extracranial. Okay, that is arising from the neural crest cells. That is neuroblastoma. And Ewing sarcoma, right? It is also small cell blue cell tumor, but it happens where? It happens on the bone diaphysis. Okay, it is another small cell. So the other one was retinoblastoma, and this is Ewing's that happens in the bone diaphysis. Okay, don't forget, and it is due to transported 1122 translocation. Fine. And in retinoblastoma, what you see in retinoblastoma, it's very important. This is very important. Flexner, Winter-Steiner rosettes. These are seen. And what is this two-hit hypothesis? This two-hit hypothesis means there are two alleles, right? The first allele and the second allele. So if the first allele is having a damage, and also the second allele is having a damage, then only this retinoblastoma can occur. The tumor can form. If both the alleles are affected, that both the alleles are in problem, then only this retinoblastoma tumor can come. So that is about retinoblastoma and the two-hit hypothesis. And don't forget the term Flexner, Winter-Steiner rosettes. And let's go to question number 15. Which of the following molecules are required for adhesion of leukocyte to vascular endothelial cells in acute inflammation? We have discussed this this topic in the last video. I'll just go through it once more. See, this image is enough to understand. So imagine there is a blood vessel and an injury has occurred in your hand. Okay, what happens to the blood vessel under that? The blood vessel, the leukocyte will be moving in the blood, right? These leukocytes are going to first come to the margin. They will be distributed all over, and they are going to come to the margin of the blood vessel near to the endothelium. That process is called margination. Okay, and next, after that margination, what happens? So you can see here, right? It is coming to the margin, and after that it is rolling on the endothelial surface, and that rolling is mediated by what? Selectins. And after that they get adhered to the endothelium. That adhesion is done by what? Integrin. It's kind of integration, right? Integration of the leukocyte to the endothelial wall. That is called integrin. That what helps in this integration is integrin. And after that, these cells are going to seep through this endothelial wall. That is called diapedesis, and it is done by what? PECAM, PECAM, and it goes near the site of the injury, and that process is called what? Chemotaxis. That is the whole process taking place in an acute inflammatory response. And the question was what helps in the adhesion? Adhesion is what? Integration. That is integrin. Okay, that is the answer. Hope you understood the concept. It's easy, right? And next is question number 16. A patient undergoes a surgery on the anterior chest wall. Post-surgery, he notices a lesion having itching and present within the margins of the wound. Okay, so here, see the options. The person is having what? He had already undergone a surgery, and now the patient is having a lesion that is having itching and also is present within the margin of the wound. Okay, so keep that in mind, those words. So first option is lipoma. It's not lipoma because lipoma is what? It is a benign fatty tumor. It's not lipoma. And see, normal granulation tissue. If it was normal granulation tissue, then the person is not going to have what a lesion kind of thing. Okay, so it's not normal granulation, it's not lipoma. Now we have keloid and hypertrophic scar. So now let's see how do we differentiate between this keloid and hypertrophic scar. Okay, see, we have a table here. The hypertrophic scar, the itching is always present, and in keloid itching is very severe and it worsens after 1 year. Okay, and in hypertrophic scar it does not cross the boundary of original incision. It will be there. So in this case also we saw what it was there within the boundary of the original incision, right? So it is hypertrophic scar in this case. But in keloid what happens is that this is going to extend towards the normal tissues like claw-like lesions. It is going to extend. So and what you can see is that there in this hypertrophic scar it is formed by mature fibroblast, but in keloid it is formed by immature fibroblast and immature blood vessels. So what happens is that there is a high tendency to recur and in case of collagen. I mean in case of keloid, sorry. And there are collagen bundles in the keloid is absent. So this is how you differentiate between hypertrophic scar and keloid. So if it is worsening after 1 year with severe itching and crossing the original incision boundaries, then it is definitely keloid. And the other thing is hypertrophic scar. In this question, it was hypertrophic scar. Hope you understood the concept. And next is question number 17. So let's read. Macrophages play an important role in phagocytosis and chronic inflammation. Which of the following cells perform the same function in the liver? You know, when it's liver, it's always the Kupffer cells. It's a very easy question, but these easy questions, they help you score very well. See, Kupffer cells. You can see the Kupffer cell here. It is found where the location of the Kupffer cell is the luminal face of the endothelial cell adjacent to hepatocytes. It acts as what? The macrophage. It's a security system of the liver. Kupffer cells. Okay. And we have other options there. What were they? The Merkel cell. You know what is Merkel cell, right? It is found in the skin and they are what? Mechanoreceptors. And in the Hofbauer cell is present in similar to the Kupffer cell, there is a cell called Hofbauer cell that is present in the placenta. And stellate cell. What is stellate cell? It is present in space of Dissay between the hepatocyte and the sinusoidal endothelial cells. What does the stellate cell do? The stellate cell, when it is active, it secretes collagen. So when the person is undergoing a fibrosis of the liver, cirrhosis, what happens is that the stellate cell is active and they secrete collagen. Okay, that is what you have to remember, and also the location. It is in the space of Dissay. The stellate cells. Keep all this in mind. Important topic. And next is a patient died of myocardial infarction and his heart was taken out and immersed in a solution. So we have already learned this. I discussed this thing before. When it is heart, and myocardial infarction, it is always what I have told: triphenyl tetrazolium chloride. So the answer is triphenyl tetrazolium chloride. Okay. What it imparts what color? Brick red color to non-infarcted myocardium. Okay. If it is you keep in mind when it is MI heart cells, it's always triphenyl tetrazolium chloride. Now this is the last question. Question number 19. Stellate granuloma is found in. So stellate granuloma is found in cat scratch disease. So let's see what this cat scratch disease is. It's like a tongue twister, right? Cat scratch disease, yeah. So this is a very important topic. You can get more questions from cat scratch. So I have given an image here for for you to remember better. So what is cat scratch disease? This disease is caused by what? Bartonella henselae. This is caused by Bartonella henselae, and this bacteria is normally spread by the fleas that are present in cats. Okay, so if you get a bite or a scratch or a lick on a broken skin from a cat, then infected with this, then you have chances to get cat scratch disease. So when you take the history of the patient coming to visit you, you have to ask the exposure of cats. Okay, and also this, what are the symptoms? Symptoms are like normal fever, fatigue, headache, and what you have to notice that there can be tender lymph nodes near the site of the injury. You have to check the person where if the person is having any bite or scratches, and the nearby lymph node has to be checked, because there can be lymphadenopathy. If it is cat scratch, see here it is. See here, it is a scratch, and here the lymph nodes are enlarged. So you have to ask the exposure and check whether there is any marks like this. And normally it resolves with without treatment, and sometimes in very severe cases we have to treat with antibiotics, and normally azithromycin is used. Okay, so how to prevent? Wash hands when you contact with the have contact, and don't have a rough play with the cats. You know, cats are aggressive. Okay, so that is the end of the questions we have discussed, and the 20th is not a question. It's a very important topic of genetics. That is, we have 4 type of transmission, right? The autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. So how do you differentiate between these? And what are the diseases that comes under these 4 headings? Okay, that is what we are going to discuss. In autosomal dominant, what happens? I have already told. If one mutated copy of the gene is present in each cell, then that can cause the disease. That is called autosomal dominant. Only one mutated copy of the gene in each cell. And how to differentiate? All the generation will be having a positive person, a diseased person. Okay, that is autosomal dominant. So here there is a mnemonic for you. It is dominant itself. See, dystrophic myotonic and osteogenesis imperfecta, Marfan syndrome, intermittent porphyria, Noonan syndrome, adult polycystic kidney, neurofibromatosis, tuberous sclerosis. This you have to learn this way. If they always mention whether it is autosomal recessive, autosomal dominant, maybe the options all can be autosomal recessive, and the answer can be autosomal dominant. So if you know this, you can answer the question correctly without reading the rest of the question, maybe. So please learn this thing. Dominant, that is a mnemonic for autosomal dominant. And in autosomal recessive, what happens is that there is 2 mutated copies of gene in each cell. In dominant, it was 1 mutated copy. Here it is 2 mutated copy, and in all the generation there may not be diseased person. There can be skipped generations, the generation without a person who has the disease. Okay, and that this is the mnemonic: A, B, C, D, E, F, G, H, and S, P, W. Okay, just screenshot this. I'm not reading all this. You can screenshot and just learn this. You have to by heart this with the help of this mnemonic. Okay, albinism, beta thalassemia, we have already done that. Cystic fibrosis, deafness, all this. Okay, so this is the mnemonic you can go through. And next is the X-linked dominant. What happens in X-linked dominant? It is always related to X chromosome. So if it is dominant, X is what? X is always related to females, right? So X-linked dominant means the female will be affected and not the male. Okay, so X-linked dominant means always the females are affected. Fine. And I have a mnemonic for that too. That is Vikram ran from India alone. Okay, Vikram ran from India alone. VRFIA. That is vitamin D resistant rickets, Rett syndrome, Fragile X, Incognitia pigmenti, and Alport syndrome. So you can remember Vikram or Vivan or whatever you like, ran from India alone. So this is the way to remember X-linked dominant. Okay. And what is X-linked recessive? X-linked recessive means what? Only one X is affected, right? That means the male are tend to be affected more than the females. Females are usually carriers, and males are affected more than the females. That is X-linked recessive. Fine. So what are the diseases that come under X-linked recessive? G6PD, Duchenne muscular dystrophy, and hemophilia A. Okay. GDH. GDH is a short form. G6PD, Duchenne muscular dystrophy, and hemophilia A. So just keep one thing in mind. If mostly females are affected, means it's X-linked dominant. If more males are affected, means it is X-linked recessive. And if if you see a pedigree chart, and there you can, what you see there is a transmission from son to father, the father to son, then it is mostly what, autosomal kind of thing. Okay, mostly autosomal dominant. That is about the genetics that you have to keep in mind. So that is the end of the discussion, the second day, the last day of our pathology revision. So hope you guys do well in your exams. Don't worry, this is going to be fine. Just go through all these topics, you'll do pathology well. These are all the main topics I have already discussed, all the main topics and the important concepts that you have to keep in mind. Just what you need is some common sense, and just be calm, eliminate the options that you don't feel right, and just you will get the correct answer. Don't worry. So do well. Don't get tensed. It's like a part of life, right? Chill and go and write your exam. It's going to be fine. So just think that this is going to happen well for me, and just go. It will happen well for you. Okay. So all the best. You are the best. Do well. So if you have any questions, and if you have any doubts, you can ask me on my channel, LearnElevate, or you can ask on my Instagram page. So that's it for today, guys. I hope you like the revision video, and for more videos we are coming up with regular classes and live and all on the LearnElevate channel. So stay tuned. We'll be making pathology more interesting with all the stories and illustrations and fun. So stay tuned, guys, and do well for the exam. Thank you.